So welcome back to the second day. I hope you all agree that yesterday was a fantastic day. So thank you for all the speakers, all the workshop leads. I think it was really brilliant, and I'm pleased to see everybody back again today. So I'm just going to do a really quick introduction, a welcome, just tell you what's happening today, and then we're going to move straight into our discussion here, our insight discussion with our speakers. So I'll introduce them in a minute. So you've all seen the coffee and the networking. Just to say that today we are based in and around this area. So we're mainly in here, and then the refreshments and the lunch will be outside. So now I'm just doing the welcome, then we're going to do an insight discussion. We've got 90 minutes for that, so the speakers are going to speak for about 15 minutes each, and then we'll have a chance for questions, discussion. Have a short refreshment break. In planning this, the most important thing for those who've been planning it has been the refreshment breaks, so I hope you're all recognising that. And then we're going to move into the second part of our session, which is about future directions. So there'll be 2 workshops, one of which is led by me, and that's in here. The other one is being led by Annette Boas, and that's just along the corridor and round. Very close, apparently. And I've been told to say if anybody goes missing, we just need to tell the team and they'll go and find them from another floor and bring them back. So that seems quite a good offer to me. Then there'll be another refreshment break, and then we'll have we'll finish the discussions with a critical discussion of a panel of us. Again, that's going to be chaired by Annette. Then there'll be lunch, and then we're finishing off with Carl, who's going to do a methods practical. And I think quite a few of you have signed up for that, and that is going to be back in here. So I think it's a really exciting programme. I hope you all enjoy. And so what I'm going to do now is just ask, rather than me painfully reading out who everybody is, I'm going to give you a bit of an oversight about what we're doing now, and then if I can just find my right page, and then I'll get the speakers to introduce themselves. So the idea of this session here is to just have a bit of a discussion of a range of different people who are taking different approaches to thinking about implementation. So we've pulled our panel together here. What we want to do is think about different ways of managing implementation across different types of practice and different settings, to give us some ideas, some ways of thinking about implementation processes, how they vary, how people approach implementation, and thinking about different ways in which innovative qualitative methods are used. So the whole idea for putting together this event has been around those of us who use qualitative methods in terms of implementation, and wanting to just think about what we do, but not tell you what we do, to be together with a group of people who are interested, to start getting this discussion going about how can we use methods, how can we think about how we use methods, how do we combine things, and what Tracy and Tim were saying yesterday about just thinking about how we can almost make it up, not having to follow these protocols all the time. What would work in this setting? How do we bring different bits of knowledge around? What do we think about it? So we very much want this to be about all your ideas. We're really excited by the range of people we've got here, the range of experience, different projects, people from all ranges, all career stages, which is lovely, and people to just think about. It's all about thinking, ideas, us all combining to make something, as opposed to come in, just learn something from people who are standing up telling you. So it's all about discussion and just thinking about that. So what our speakers are going to do today is just tell you a bit about what they do, share it from their settings, their approaches, and then from that we can start thinking about how we might combine, what you might add to that, questions you've got for them. So I'm going to work my way along and ask each person to introduce themselves, say who they are, where they've come from. It sounds a bit like Blind Date, doesn't it, for those of you who are old enough to remember, and the kind of work they do, and then we'll get people to speak. So Kristian, do you want to kick off?
Yes, hello everyone. Oh, wow. My name's Kristian. I'm based at the Yorkshire Humber ARC. I also work in the Improvement Academy there. And for the last 8 years or so, I've been very interested in implementation. First, sort of, for my PhD, we were trying to implement mindfulness meditation into schools across Cumbria. So you had over 320 schools, and I knew that we'd probably get a 10% success rate if we didn't come up with some kind of implementation strategy. Yes, we tried to. I spent 3 years trying to work out how to get more than 10% to sustain it and keep it in place, and then started working with the Improvement Academy. And I suppose I'm just really interested in how can we get an impact? it's all very well doing the problem analysis. If you look at papers on climate change, for example, like 98% roughly talk about the problem of climate change, and only a fraction will talk about implementing solutions. And the only way you learn to implement solutions is by trying to implement solutions. So I'm a very practical implementation researcher, I suppose, and I work with hospitals and schools and people in the community to try to get a better impact. So I'll be talking about evaluating implementation today, and I look forward to it. Thank you.
Thanks, Kristian. Sarah?
Morning, everybody. I'm Sarah Beardon. I'm a research fellow based at the UCL Faculty of Laws. I should say I'm not a lawyer by background. My subject background is in public health, and I've been working with the legal field for 6 or 7 years now in health justice partnership, which I'll tell you more about in my presentation. I did my PhD in the implementation of health justice partnerships across England, which was an ARC-funded study. So that's what I'll be talking about today. And my work now is very much more in policy engagement and supporting practice rather than research, just based on the recognition that doing more research is not going to necessarily produce change, and we need to do some advocacy and engagement work. Thank you.
Thanks, Sarah.
Hi everyone. I'm Charitini Stavropoulou. I'm a reader in health services research at City University here down the road. And I'm the co-director of the Center for Healthcare Innovation Research at City, which sits between the School of Health and Psychological Sciences, where I'm based, and the business school at City University, with the idea of bringing together different disciplines to understand what we call the spread challenge. So the idea that innovation is, we are great in coming up with new ideas, but not very good in spreading it more widely. So maybe I give a bit of my background, which I hope it doesn't shock you. I didn't train in qualitative methods. In fact, my PhD was in health economics, but I became increasingly interested in the use of qualitative research because not every question can be answered quantitatively, and I consider myself a mixed methods person. And today I will be talking about one piece of work that we are doing at the Center for Healthcare Innovation Research, which is around the role of pilots in spreading innovation, mobilizing evidence, and supporting the spread of innovation, and try to give a sort of understanding of what we call the pilotitis issue when it comes to mobilizing evidence.
Thank you. Thank you, three. Sarah, do you want to come up? The slides are all reloaded here, so hopefully there was a pace like just a bit.
Great, okay. So I've done the introductions. So the presentation that I'll be focusing on today is the study design and research methods that I used within the fieldwork for my PhD. So firstly, a brief introduction to health justice partnerships. So in a nutshell, what we mean by this is the integration of welfare rights advice with healthcare. And these partnerships exist all over the country in different healthcare settings, in different forms, different ways of designing and implementing these partnerships. And I've pasted a link here to a report if anybody's interested, because I'm not going to go into detail about that. But firstly, what do we mean by welfare rights? So welfare rights are the rights that we have under social welfare law. Those areas of law are listed here, and these laws are essentially safety net laws that exist to make sure that we have access to basic resources and protections. So it might be things like a reasonable level of income, it might be decent living and working conditions, access to basic services like education and social care. And these rights and what the law says about these issues obviously very strongly shapes the society that we live in, but also the experiences that we have during our lives. But equally important is whether we actually understand our rights and we're able to secure the support that we are legally entitled to, for which we may need legal advice and assistance. So I'm hoping, something else to mention here is that that some of you familiar with health inequalities issues, this might be ringing some bells, because many of the social determinants of health have a legal dimension to them and possibly a legal solution. So we don't just have to accept that people are living in terrible conditions because they have rights, and those rights can be enforced if they have access to the legal representation that they need. So this is definitely an intervention that we can use against health inequalities. You know, it's one thing that we can do among many. So integrating welfare rights advice with healthcare is partly about reaching people who are in need of this assistance, because very often these welfare rights issues arise as a result of illness, disability, mental health conditions. So it's about reaching in to the people that need this support the most, but also, of course, addressing those underlying causes of poor health and supporting the healthcare teams who come across this all the time and need to be able to offer people appropriate assistance. So before starting my PhD, I'd worked in the subject already for a couple of years. I'd connected with many of these partnerships across England, and I could see how important this work was, but I was also coming across the implementation challenges again and again, just talking to people about the difficulties in developing and sustaining these partnerships. So for me, there was a question about how we go about this successfully. So in terms of the methods, the research question that I was answering here was what underlying factors influence differences in success of health justice partnerships at an organisational level. So I think this is a slightly unusual angle potentially for an implementation study, because often implementation research is about the initiation. It's starting something, getting it off the ground. But in this study, I wanted to learn from the variation and why was it that things were working so much better in some places than others. And I should say also that health justice partnerships are not new. This is not a new innovation. They've existed for decades, but they've not become widespread because they've not been included in policy, either healthcare policy or legal policy. There's no funding for them, there's no coordination, no guidance. So I wanted to do some research that would be able to produce some recommendations to support their implementation. So to answer this question, I used a comparative case study design, which is, as it sounds like, it's case-based and it's comparative. So case-based research really focuses on trying to gain that in-depth, qualitative, holistic understanding of a system within the context of its natural setting. And then the comparative element is that you repeat those case studies with a number of services that you choose purposefully to enable you to answer the research questions by comparison of different contexts or different outcomes. And having that broader scope and more than one case study allows you to look a bit more carefully, I guess, at the causal patterns. What are the factors that are leading to these outcomes? And it allows you to also generalize a bit further beyond one particular setting. So the analysis of comparative case studies always combines within case analysis to explore how things work within the individual case study examples that you look at. So you can look at mechanisms, causal pathways, and also across case analysis to look at the patterns across the sample. And that allows you to look at the relationships between particular conditions and the outcomes that you see in those cases, which can help you to look at causality. So in terms of my study design, I had 9 partnerships in different regions and different care settings across England, and I had selected them deliberately for different implementation outcomes. So there were 2 outcomes that I was interested in based on having connected with services and realizing the challenges that they were having. So the first was collaborative working. There are often challenges around this. You can put a legal advice service within a GP practice, but the GPs may take no notice of it at all. So that is important because we know that for the impacts of these partnerships, that collaborative working has to take place in terms of access for the patients, but also their outcomes, because your legal rights and entitlements often depend on your health condition. So that information needs to be transferred. These teams need to be working together. The second issue I decided to focus on was sustainability, because, again, it's another major issue for health justice partnerships. There are services that have been around for 30 years or more, but very often they'll pop up as a pilot and they'll disappear again a couple of years later. And this has a lot to do with political and funding issues within the legal advice sector, which I won't go into, but if anyone's interested, happy to discuss. In terms of the data collection, I was doing semi-structured interviews with professionals within the services, which included the legal advice teams, the healthcare teams, the managers, and the funders. I should say that I did this during COVID, so I was doing the data collection between February and September 2020. So it was a very disrupted period. I had to accept slightly fewer interviews than I ideally wanted, but it was enough to produce some useful findings. So in terms of the data analysis that I used, I first did a thematic analysis as my initial exploratory step to essentially code and organize the data. And then I used two separate analyses to look at the causal influences, which I'll explain in a bit more detail now. So the process tracing was my within-case analysis, and the QCA was my cross-case method. So process tracing essentially traces a causal process and identifies the mechanisms that link causes to effects. So the aim is to directly observe how an outcome is produced within an individual case example. So in practice, essentially, this involves identifying and coding for relationships in the data. So it was fairly straightforward in terms of the actual practicalities of it. And I used this inductively because I wanted to explore the relationships that I could find in the data as fully as possible before imposing any kind of theoretical structure on that. Qualitative comparative analysis is a mixed method, so it applies a quantitative analysis to qualitative data, and it looks at relationships between particular conditions and outcomes across the case study sample. And by doing that, it identifies the nature of the causal relationships based on how factors combine into sets. So it can tell you about which conditions are necessary or sufficient for a particular outcome. And I used QCA deductively, so I was drawing on an implementation theory to help me narrow in on the factors that were likely to be causal and explanatory. That theory was the general theory of implementation. So to give you an idea of what this actually involves, because it's not very common, I think, essentially you draw up a table. Sorry, I've just lost my notes. Hang on. So each row is a service, each column is either a condition or an outcome, and as a researcher you make the decisions about how to define those conditions and how to measure them as well. So to me this felt like a very qualitative process because it was looking at the data, looking at the patterns that I could see across the case studies, looking at the theory, and making judgments about how to best represent the patterns that I was seeing. And then the table is converted into an algebraic equation using the expressions of and, or, and not. You can see how that's done here. And then essentially the calculation reduces that equation logically to give you a solution that tells you what is the minimum combination of conditions that's sufficient for this outcome. So I'm going to show you the results now to give you an example of what these methods can give you and what that might look like. So my first step, I'm just going to show you the one outcome just for time reasons, and I've chosen the collaborative working outcome. So my first step here was simply to describe the outcome. So in some partnerships, the partnership working, the collaborative working was really quite limited. So all that was happening was the occasional referral was coming into the legal advice service from the GPs. But in others, it was much more involved. So the healthcare teams would be very actively engaged in identifying those legal needs, communicating with the legal advice professionals, exchanging medical evidence, providing feedback on how someone's situation was developing, potentially contributing to the legal casework together. So there were teams that were very much more working closely together, and I could see that pattern already quite clearly and quite soon. So the process tracing results essentially identified the fine detail, so it looked at the mechanisms and the wider context that had an influence on whether or not people would engage in these activities. So I know the diagrams are too small, and I really just put them up to show you the kind of detail and complexity that you could get from a process tracing analysis. It shows the relationships, the links between things, the feedback loops. And just to give you an example of a process that you could trace, locating the services together meant that the teams had opportunities to interact with each other day to day, which in turn meant that they could increase their knowledge by talking to each other, they could build relationships with each other. Both of those things improved their sentiments and positivity towards the partnership, which in turn encouraged them to work together. And by working together, they realized the value, and it was a sort of a positive feedback loop. So there were many such processes that you could trace, and that gave you, all the sort of detailed depiction, and I had a long description of all those themes and the relationships, which is good, to get into that detail. But I think if you gave that to a manager, they'd probably say, well, thanks very much, but what do I focus on? Tell me the 3 things that are important. And this is where QCA can be useful. So in the QCA model that I developed, there were 3 conditions that I formulated that I thought were having a strong influence on the outcomes. The first was communication opportunities, so the ability of the teams to actually interact and communicate during their day-to-day work, which could be determined both by physical and administrative barriers. The second was collective commitment, which was about the team's willingness to engage, that having an inclusive team culture and really embracing that partnership at the team level. And the third was leadership facilitation, so everything that was being done to facilitate and encourage that partnership working, including educations, induction, promotion, championing roles, brokering those relationships actively if there were problems, so that sort of active facilitation. And these are the combinations that you saw where the collaborative working was close. So you can see 3 partnerships on the left there, which had high levels of all of these predictive factors. There was one case study where the leadership facilitation was not particularly strong, but this was actually a partnership that had existed for about 15 years. It was so well embedded that they didn't really need to keep encouraging and promoting, and it was just part of how things worked in that setting. So what this solution formula tells you is that where communication opportunities are high and collective commitment is high, that is sufficient for collaborative working to be close. If you look at the cases where collaborative working was not close, you can see that 3 of the services lacked all of those predictive factors. A couple of them had quite a lot going on in terms of leadership facilitation, lots of promotion and sort of awareness raising about the partnership, but those teams actually lacked that ability to come together and communicate day to day, and possibly partly due to that, they didn't have that sort of collective commitment and team culture. So what the solution formula there tells you is that where communication opportunities are not high and collective commitment is not high, that is sufficient for collaborative working to not be close. So I hope this gives you a sort of feeling for the kind of thing that QCA can be used for. It's one tool. If it's useful in answering your questions, then it's something to consider. So just some very brief conclusions, things that I felt worked well in the methods were designing the sample for comparison from the outset. I think there are things that I never would have identified if I'd had case studies that all had a similar outcome or that were very similar in terms of their contexts. I think having that diversity of context and the outcome allowed me to explore the real influences there. And also using both within case and cross-case analysis. So the process tracing really gave you that depth and complexity and allowed you to look at the detail and the causal pathways as a start, and then QCA helped you just to zone in and gave you a bit more clarity, and these are the takeaway messages. Challenges of the study, obviously the recruitment during COVID, which made everything slightly compressed in terms of timelines, engaging with some of the managers because I relied on them to do the promotion and recruitment for the study, and representation of healthcare professionals, particularly in primary care. And I know it's hard at the best of times to recruit healthcare professionals in research sometimes, but during COVID it was particularly difficult. And in terms of the sustainability outcomes that I looked at as well, definitely some sensitivity around closed down services, people not really wanting to talk, or when I did talk to them being a bit defensive about their decisions, so those interviews were not very easy. I've put a link to our website here if you're interested in the subject, and my email if you'd like to get in touch. Thank you.
I think it's been about 5 years since I've done this. It's always on Zoom these days. So, right, let's have a look. Yes. So rapid, relevant, and responsive, evolving how we evaluate implementation. So I'm just, you know who I am. So I'm just going to go through a bit of background today, show a traditional approach to evaluating implementation, explain how we might be able to build on that, and then go through an example. So, I mean, in my experience within my ARC, the Yorkshire Humber ARC, projects are increasingly asking for independent implementation evaluations. You might ask why? Well, it's a bit like, well, this is what some of them said. So I know how to implement this, but I'm so busy doing that I don't have time to evaluate it, to collect data, to keep a record. So a lot of the time we have practitioners on the ground who are very used to having to implement things, but they just simply don't have time to actually keep a record and scientifically analyze what's happening. What we are learning is not getting back into the literature because it's not captured. So I think a lot of people in these settings they're experts of their own context, and they're the ones learning how to implement because they're doing it. And so often what they learn isn't getting back into the literature. It's another reason for us to evaluate. And one person said to me, I'm the potato farmer and I need an agricultural scientist. So they're very good at planting potatoes, but they need somebody there at the side of the field just, watching what's happening, learning, seeing how they respond to things as they come along. So if we're going to offer evaluations to these teams of people, which could be researchers, could be practitioners, could be a mixture, it's often a mixture, I think we need to innovate. And this paper is from actually 10 years ago now, but it really struck me. It's saying rapid, responsive, and relevant research, a call for rapid learning health research enterprise. And it's just basically saying what the authors were saying. Health research enterprise is painstakingly slow. So results seldom translate into practice, and if they do, times have moved on, things have changed, they're not always as relevant. And they were talking at this idea about need for more rapid, responsive, relevant research and proposing greater stakeholder involvement and speed research via innovative designs, as well as some other things. Now, in my view, implementation or process evaluations, people like to sometimes call it, are no different. I think we also possibly need to be rapid, responsive, and relevant when we do those. So that's something I was thinking about. As I was saying in the introduction, I'm always thinking about impact. So what's the traditional evaluation like? Well, we'll often have an evaluation with a defined set of outcomes taking place over 1, 2, 3 years, maybe longer. You'll have your evidence-based practice, but this could also be an idea or a change process or an improvement process. You'll have the implementation, and then at the end, we'll have intervention outcomes, implementation outcomes, and maybe something deeper about the context. And so measures that people often use are often, I've seen this, they use Proctor's measures. These are very useful, academic, generalizable. You can apply them to any setting, any intervention. So was it acceptable? Did people think it was palatable? Was it adopted? Was action taken to implement it? Appropriate? Was it compatible with the environment? These kind of things, very interesting. We'll also use something like an implementation framework. This is the CFA, the Consolidated Framework for Implementation Research, and it's a determinant framework, so it's saying, well, there's all these factors that can affect implementation. So at the end of the 3 years, we will know whether the intervention was effective or not, where it did and didn't get implemented, and something about the context, barriers and facilitators, provider attitudes, behaviors, system penetration, appropriateness, implementation cost. This is what a lot of evaluations have been like. And I suppose you might say, well, that's great, isn't it? We know something about the implementation, we've evaluated it. But is this enough? That's the question. Do we need to know more than this? Well, let's just try, it's very hard to do, but let's look at what implementation might actually be, right? Implementing research into practice is extremely complex, it's unpredictable, it's non-linear, right? So it's not like baking a cake or building a rocket ship where we follow steps, we'll eventually end up with a cake or a rocket. We kind of can imagine what some of the problems might be. With the cake, it's quite simple. Most of us could do it. The rocket, you probably need an expert, but you eventually get there. Whereas implementation is more like raising a child. You just don't know what they're going to do from 1 minute to the next. You don't know what barriers, problems, the context is going to throw up at you. So this model's quite useful. So we've got the goal. This is the intervention. This is where we're heading, right? The where, that's the context, and the people involved that will need to do the implementation. And we'll also have the method of how we actually get there. So this is a very simple way of trying to address this complexity, that this context, every single one is different. Different relationships, different people with different capacity, different time, different beliefs about the intervention, different external factors. So the list is endless. And these things are constantly interacting. So these participants are trying to achieve this goal in this context using a certain method all the time. I can't take credit for this. This is Gabby and LeMay. They presented this, a keynote presentation at the UK Knowledge Mobilization Forum in 2019. And I think they were just really saying, well, a lot of the framework, a lot of models, theories, and frameworks for implementation science are kind of saying things like this. So I find it very useful. Now, what I've added here is this, what I like to call within system learning, is that as all these things are interacting, and as these people are trying to achieve this goal in this context, they are learning a lot about implementation. And I think that we really need to be capturing that if we want to know how to implement and also how the implementation really went. So I think my feeling is most process evaluations fail to capture in detail the ongoing interaction between these components. They fail to capture the within system learning. So what does that mean? Well, we don't really learn how to implement. So at the end of the 3 years, knowing that it was acceptable or not doesn't really tell anybody tasked with implementing it again how to implement it. We carry out mostly problem analysis, as I was saying with the climate change example. So this makes it harder to know how to have impact. So back to our process evaluation, we've got our evidence-based practice, our idea, our concept, we've got the implementation process, and we've got the outcomes. But instead, what I'm saying is, well, let's look at this as an ongoing process of learning throughout. Let's try to capture that complexity. Now, rapid, relevant, responsive, right? How can we make it like this? Well, firstly, rapid. You just start collecting data a lot more frequently. Every week, every 2 weeks. Let's not wait 3 years to know if it's working or not. Let's know in the first week. We've got a number of projects we're doing with this at the moment. So some GP practices who have been tasked with implementing a whole new process, extremely complicated. We're talking to them every 2 weeks to find out how it's going. Now, you might say, how do you do that? Because that's a lot of data. Well, we use rapid qualitative analysis, and I'll give you an example of this in a moment. And there's lots of ways you could do it, but that's one way. So relevant. Well, it's probably more relevant because hopefully we're getting some of that within system learning. As these people are engaged in the process of implementation, they're hitting all these problems. Oh my God, there's something on political just changed, or someone just quit. How do they overcome it? And that's that practical knowledge. That's going to be more relevant for people in the future, we think, right? Because then it's going to give them some key insights into how to actually implement this in an unknown situation. Now, it's also responsive because we're learning as we're going along. So, and everybody's clued into what's going on. So now we can decide whether we want to respond to it or not. So I'll show you in a minute, but the way we actually feed back what we're evaluating to the people doing the implementation then gives them something to respond to. So rapid, relevant, responsive. Let's look at an example. Now, I'll be honest, this is a kind of perfect example in a way, but it is a real example. I won't go into too much detail about the project because it's not been published yet. We're still analyzing the results. But it was an intervention to try to, tackle the winter pressures. You may have heard, seen those pictures of ambulances queuing up outside hospitals. Well, this was really to try to decrease that. And so if you look at the context goal method participation, right, this really was very strong. So we actually were very lucky. We had an improvement specialist working with us who understood the context because he'd worked as a paramedic previously. He'd designed the intervention himself, so he really understood how this thing worked and what the goal was. He knew exactly who he needed to speak to. And he also brought a method of implementation, which was tests of change, which is an improvement practice, right? So he started off with engagement. Now, engagement is probably the most important thing, I think, when it comes to implementation. It's the thing which makes everything else work. So to understand your context, to know who to speak to get people understanding where you're heading, to get a method that works, you need to engage people. And that's what he did. So he went to speak to the ICB high-level staff, told them about how this thing works. He used to travel around the country speaking to the ICBs, trying to find out who might be interested. Now, if they weren't interested, he'd move on to the next place, but he would eventually find somewhere that was. Then he would engage the leads, the managers, and actually really talk to them. What do they need to make this happen? And get them on board. And then he would engage the frontline staff. So we've got this engagement. So now we've got somebody that's really delving into this context and really getting to know these participants. And then he's saying, look, let's not try and implement this for a year. Let's just try a 5-day test of change. So they did 5 days. And if it didn't work after that, they'd pack everything up and forget about it. But no, so it's a nice bite-sized way to get people interested. They got everything ready. They had this room set up. It was for this, it's like a hub with a district nurse, doctor, ambulance service member that were taking calls off the ambulance call stack and trying to address calls with community teams rather than sending ambulances. So this was the kind of way it was trying to work. And so in the first 5 days, they started to take a lot of calls off the ambulance service. And so then it was allowed to do another month test of change, then another month, and then another month. And now it's pretty much embedded. So what did we do? Well, what I was saying, we did a rapid, relevant, and responsive evaluation. So we would contact the team doing the implementation every 2 weeks. The first time we went to see them, we went in person. We spoke to everybody on the day. And then we just keep in touch to ask them how it's going. Now, we were evaluating not just the actual intervention, but the implementation process. We wanted to know, is this a good way to implement this kind of thing in these settings? So now we use these things called lightning reports, which is a rapid qualitative analysis approach. I'm going to show you that in a minute. And we would feed those back to the team. We also did more traditional evaluation. So we did baseline interviews, and interviews at the end, and we use the CIFA to analyze the interviews, field notes, and also the lightning reports. So this is a paper about lightning reports. I've spoken to Katie Brown-Johnson. She's a great researcher based in California. She developed these. The beautiful thing about lightning reports is they're very simple. Pretty much anyone can use them. And the analytical structure really is saying, well, plus is what works, delta, what needs to be changed, and insights, participant or evaluator insights, ideas, and recommendations. So what we have, this is the basic structure of a lightning report. And as you can see, the plus section, positives, what's working, what's going well, the risks, what needs to be changed, what's not going so well, and insights. And you know, you can go into a setting where they're trying to do the implementation. So you've got this busy hub dealing with all these problems. Just ask them, each person, how's it going? What's going well? Is the test of change working? What don't you like? Any key insights? And so the cool thing is you can member check this. So you can fill these out literally the same day, right? Or maybe it takes a day or two, but then feed it back to the team and say, did we miss anything? And that actually gets them more engaged in the implementation. We were saying yesterday how people don't have time to problem solve implementation. Well, what I'm trying to do here is just sneak in time, right? Can I talk to you for 10 minutes on the phone every 2 weeks to ask you how it's going? It actually gets them thinking about implementation, even if they don't have time. It's very important to get the executive summary right, because we'll give this to the exec, we'll give this to the funders, we'll give this to the research team, we'll even show it to patients, but they might not have time to read the whole thing. So just get that top bit right. And it can take a while to decide what to put in there, because you might have so much that you need to work that out. It's intentionally created to look nice. So we don't want it to look like all the reports that people get. Now, this is not an example from our study, because we're still going through that. I didn't want to put the data up just yet. But this is from Stanford. They sent this through. And you can see this is one page. And this is where they spoke to 19 people. And it's about another process called Primary Care 2.0. You've got those positives, room to grow, and ideas. And like I say, you can feed this back. So what we found with this, we're only just started using it this year, really. But we're about to use it with the GP practices. And with this project, that firstly, the leads really liked having a record of what's happened. So imagine, like those potato farmers, extremely busy trying to plant potatoes, and now somebody's actually giving them a sort of, it could be every week, every 2 weeks, every month, every 2 months. This is what everybody is saying is happening. This is what's going well. This is what's going well. They've got a record now. They've got something they can submit to the funders if they need to. It can facilitate implementation. So I think it can grease the wheels of within-system learning, because we're actually asking them and inviting them on a regular basis to reflect on how the implementation is going and overcome problems together and work on insights and even share our own insights. And I think a really great question I've obviously had about this is, you know, what about if you're not around? How could you replicate this? Well, I think lightning reports, as I said before, are quite straightforward. I think we might be able to train pretty much any team to use these themselves. So I think it is more rapid because of all the reasons I've explained, and it's more relevant because I think we're getting more interesting, not just the generalizable academic findings, but some really interesting examples of how problems were overcome, what people are thinking all the way throughout, and we're responding to that. But look, let's look at the reality. This example I've shown is kind of a perfect example. Like most practitioners might not have time to do a rapid cycle or a test of change. Research teams don't usually have improvement specialists. There isn't usually the funding and time to do any sort of improvement practices or test of change in this case. Also, research teams. I've been using the CIFA a lot, and some of the other frameworks more recently. And teams take it takes a long time to learn them if they're using those. So it's not always so great. And this issue of replicability there, then, because these things might not be in place. So I think we need really pragmatic and easy ways to evaluate that research teams can do, or practitioners can do if there's no research team, or they can all do together. And I think it needs to be, it's there. It needs to be rapid, relevant, and responsive, so it's doable for most people. So we're still working this out, but I think the basics for any pragmatic approach is, firstly, just understand the context. There might be multiple settings within this context, but that is the starting point, to talk to as many people as possible and engage as many people as possible. So we can actually find the people involved in the implementation, the right people to involve, and agree, what's the goal? Where are we heading? Because if you think about it, we can be very clear about the problem and we can be very clear about what the goal is, but we need to allow that flexibility in how to get there. If we don't know what the goal is, then we don't know what functioning is, and we can get lost. So it's very important. If you know where you're going, you can allow all that movement within. Then regular contact, because I think there's so many good reasons to do this. We're going to get better data because we're going to sort of encourage within system learning. And it sort of means that we know what's happening all the way through ours. And I think we get a richer data set. So decide on an approach to evaluation. Now, like, we use rapid qualitative analysis, but I'm sure there's lots of ways, maybe even quantitative ways, you could be sort of knowing what's happening all the time. Facilitate, again, lightning reports is kind of like audit and feedback, but if you look at, say, the Paris framework, there's lots of ways you can facilitate. Goal setting, improvement practices, engaging people, stakeholder analysis, all these sorts of things. So now the key thing about this, and this is something which I think is where we're having to shift how we do implementation research a little bit. Because firstly, it should be an approach that works for everyone. So how we collect data, whether it's lightning reports, or whether it's by the phone, or calendar invites, or Zoom calls, that needs to work for them, and it needs to work for us, and we need to agree on that. And maybe every 2 weeks isn't suitable. Maybe the GPs are like, no way, I'm too busy. How about every month? Okay, we can do that. Or maybe we have to go see them. So just like we're expecting these people to adapt their method of implementation, how they're actually doing the implementation to these barrage of unknown contextual challenges, the research team, us as the research team, also needs to be open to adapting and changing how we do our evaluation. And I know that's a bit tricky when it comes to ethics and things like that, but we are finding ways to be very methodological and rigorous and ethical, but adaptive to the needs of the setting. So we can learn what we need to learn, and we can facilitate the best we can, and people can actually do their implementation. So the conclusion, approaches to implementation evaluation should be rapid, relevant, and responsive. Not always. Look, I'm not saying this is for always, but I think in a lot of cases it would be good. We need to be capturing within system learning and practical implementation knowledge if we are to help future teams have impact and move beyond problem analysis. I think knowing what the barriers and facilitators are and knowing if it was acceptable or not isn't quite enough if we're going to learn how to have impact and actually how to support teams to implement.
Say that again.
Thank you very much. You're supposed to weep at that point. There are many ways we could do this. Qualitative rapid analysis seems to be a good one. I really enjoy using lightning reports, and it seems to be very popular. They've spread rapidly through our ARC. We can also facilitate, which helps us get better data, more learning, and teams to implement better, and which may increase their impact. Thank you very much.
Thank you. I think can everyone hear me? Yeah, good. I gave a bit of an introduction earlier about the work we are doing at the Center for Healthcare Innovation Research, and the main remit of the center, which is to understand what supports the spread, what are the challenges of spreading innovation in healthcare. And I think I mentioned briefly that we're trying to draw on different literatures because spreading innovation for us means two things. It's about the sticking innovation that sticks and becomes sustainable, but also spreads more widely. So implementation science helps us a lot with the understanding of what helps innovation stick, but we need also other theories like organizational studies and management studies to help us with the diffusion of innovation. So that's where we stand, just to give you a bit of background as to where we do. So this is a paper that I will be presenting today with some preliminary results on what the role that pilot studies play in mobilizing the evidence that is needed to spread innovation more widely. And the setting here will be the English NHS, although as I will say in a bit, it's not just an NHS problem. It's a problem we see in many health systems. So as I said, the problem we're trying to understand here is the fact that the challenge of spreading, we have different ways we are trying to do that in practice. And one of the main ways that we are trying to help innovation spread is by generating the evidence that is needed in order to convince those who will adopt it in practice and use it more widely that this is an innovation that works and an innovation that is worth investing on. And we do know that the role of pilot studies is quite important in that sense because it does generate this evidence. But what we don't know is how these pilot studies help the wider spread of the innovation. So we know that they're useful for the local adoption. Local adopters, they want the evidence that it works for them. But what we don't know is how these pilots may help mobilize the evidence more widely so it spreads and help the wider spread of innovations. And what we see in practice, and this is the problem we're trying to understand a bit better, is an unnecessary repetition of pilot studies across of the same innovation in different localities, which obviously has huge cost implications, it's time consuming and resource draining. So those of you who have been involved with pilot implementation studies, you know that this is quite a lengthy and costly process. So this is a quote directly from the data from one of the commercial leads of one of the academic health science network that we interviewed, and they captured exactly this problem in one sentence, and I think it was a great title. When I saw this quote, I thought that should be the title of the paper, which talks about that in the NHS we have more pilots than British Airways, and indeed the idea that pilots they run for years and they don't allow us to move things forward. So what we're trying to do here is we're trying to understand a bit the reasons why we observe this phenomenon in practice. And to do that, we bring together two theoretical, I would say, lenses to understand this phenomenon. One strand of literature is that of evidence mobilization, because as I said before, we want to understand how pilots support the mobilization of evidence in practice. And evidence mobilization is really the process that involves efforts to transform practice through the circulation of knowledge. So it is following the literature of knowledge mobilization, really. And we do know that, of course, evidence means different things to different people, and different stakeholders will require different types of evidence in practice. So that is one theoretical lens that we will be applying, and the other one is the innovation journey literature, where we know that the innovation journey is not a linear process. So it doesn't start from A and goes to Z. It has ups and downs, and we do observe that the diffusion is really not just about the innovation itself. It's all about the social factors, the relationships, and the context within which it's been used. So these are the two strands of literature that we're trying to bring together to understand this issue of pilotitis, what we call. So to understand how the evidence generated for pilot studies can be used in the innovation journey to support the spread of innovation in healthcare. As I said, this is a problem that we will analyze within the English NHS, but there's evidence coming from Canada, from China, from even African countries where they're trying to implement the innovations that they highlight, exactly what they call the plague of pilots, where innovation fails to move on from a local site to another. So the methodology. So the way that this work started was from a bigger project which ran in the beginning of the pandemic, so in March 2020. It was a bigger project that involved the academic health science networks. So a structure within the NHS that supports exactly the kind of work that we are trying to do, which is the spread of innovation in healthcare. So brings together the innovators with the local NHS providers in order to support exactly this wider spread of the innovation in the NHS. And that project was really meant to understand how different HSNs use the different models that they're using in their local adoption of innovation in their regions. There are 15 HSNs in the English NHS, and they have regional responsibilities, as I said before, for the spread of innovation. So we wanted to understand the different approaches that they use in practice to support the adoption. And one of the things that became very evident was exactly the problem that we're talking about today. The fact that they were talking about how difficult they find the idea that they have to prove every time that something works, and the idea that they also call themselves pilotitis. They think that they have to again and again prove that this is something that works. So that's where the idea of this paper came in, when we thought, okay, let's try to go a bit into more depth. So that study was published in a report, And then we said, okay, from this data, let's say, how do we talk about pilots? Let's identify the ones that they really speak to this problem. And then what we did was we realized that those who had a better understanding of this problem, of the pilotitis issue, were the commercial leads, commercial directors of the HSNs. So we then went back and interviewed 16 commercial directors who were not involved in the first study, to specifically ask them about the issue of pilot studies and the use of pilots in mobilizing evidence. So you see that there was a two-stage approach, the bigger sample and the more specific sample we used for that particular problem. And ultimately, what we did was we went back to the data and we tried to identify from the 141 semi-structured interviews how many of them were talking really about the problem where we are talking here. And I ended up with really a subsample of 54 interviews that were related to the topics that we were interested here. So the approach was interactive. We did analyze the data first interactively. So I myself and another co-author went back to the data, familiarized ourselves. We tried to understand what the data was trying to show without necessarily applying the lenses of the innovation journey or evidence mobilization, just to understand really what are the main things coming out. And then, of course, when and this is the stage we are at, we're going back and forth with the theory in the data and the theory in the data to understand really what the data, what is it really that we are seeing here. And again, the setting is ideal for us because the academic health science networks, they are related to the idea of, they work in practice to spread innovation, but they're also the ones that are trying to generate the evidence. So they are perfect for bringing together these two lenses that we are trying to do here. So the data we have is the perceptions of those who are involved in the process of generating evidence and pilots in practice, and their views on what may be the explanations for the phenomenon we are interested in. So again, these are the first thoughts, first, I think, findings, and as I said before, preliminary. We started with first order concepts. We tried to understand what is it really that the participants tell us about the process of mobilizing evidence, and they talk. Then and they do talk a lot about the idea that evidence transitions not just across time, right? So we need the pilots in the beginning of the innovation journey to prove clinical effectiveness, but then we need more evidence about acceptability, issues of the technology in practice, and so on. So evidence transitions across time, but it also transitions across space. So it could be mobilized from one side to the other. So they share the knowledge that you have generated in one place to the other. But of course, the problem of pilotitis begins from also the complexity of adoption more widely. And Trisha Greenhalgh has the NAS framework is really about the whole idea of complexity of adoption. So I'm not going to go into the details of all specific things, and will highlight the ones that I think are more relevant, just as a takeaway message. So really, pilotitis is the problem of failing to transition the evidence from one place to the other and across time as well. So in a sense, what we are trying to show here, that is, if you have this two-dimensional aspect of evidence, transitioning over time or over place, the problem of pilotitis arises when you fail to go out of the loop of moving the evidence over time or across different sites. So, in that respect, the innovation journey is important because it does show that innovation, the evidence changes over time. But if you fail to make these transitions over time, that's where you end up with the unnecessary repetition of pilots in practice. So I'm only highlighting a couple of points given the lack of time, just to say that we do see that these challenges in transitioning, in making this transition of evidence over space and time, have to do with the fact that we know very much. We know from the literature that the different actors demand different type of evidence. So clinicians, they want to show that this is clinically effective in the beginning, and then later on they realize that actually yes, but managers want to know that it's also cost effective, right? So it doesn't just improve things, but it also it offers value for money. So the fact that the different evidence speaks to different actors, as we know from the literature already. And we do also know, as I said before, that the evidence changes over time, and all this evidence generation and mobilization happens within a very complex system of adoption in practice. And we're trying to figure out what are the ways in which you can manage these transitions, right? Because one thing is to say, yes, that repetition is unnecessary, but then how do you move on from that? So what we're trying to also see is what is the role of these structures, such as the HSNs, which are a network aiming to help this mobilization across space, for instance, would be, and what is it from their point of view that may support the better mobilization of evidence, so that you don't have to repeat the same thing and again in other places, which doesn't seem to be happening in practice a lot. And as I said, for us, it really pilotitis is a symptom of a problem, right? Is the fact that we are working across a very complex system, and the lack of ability to mobilize the evidence is really the essence of the problem, and pilotitis is the symptom of the disease, as one can call it. And what we do show is that indeed pilotitis, the repetition of piloted studies itself is not necessarily a bad thing if it is done in order to support evidence in areas where we have no previous evidence, or it's a completely different context. What we define as pilotative is the unnecessary use of pilots over time and space. As I said, we're back in the data and trying to dig into what the HSN members told us, and try to theorize a bit better the problem itself. And this is what we're doing at the moment. But what we really lack, and that's I think the limitation of the study, is that this phenomenon is seen through the lenses, through the eyes of those who are involved in the process of spreading and mobilizing evidence, the HSNs. But we don't have the empirical evidence, the examples of specific innovations that have been piloted over time, and this is what we would like to explore more. So follow an innovation that is being piloted in different places and try to understand the reasons why it's been done, what does it bring to new sites, and really understand a bit better the longitudinal, through the use of longitudinal studies, the problem, because it is an area which is under-theorized, but also there is extremely limited evidence of what's happening in practice. Everyone talks about it. Every commercial lead we spoke to, every innovator we speak to from in our capacity as through the center, they all talk about pilotitis. But when you ask about specific examples, give us the data, something that shows that this is happening over time, it's quite hard to find this evidence. So we would like to find a bit more empirical, I think, justification of what is happening in practice. So I'll stop here. I hope I didn't rush, and I hope that, yes, that gave you an idea of the pilotitis issue.
So thank you all three speakers. That was great. I'm going to open it up to the floor now. We've got half an hour, so that's a nice amount for questions. So, Sylvie, do people need microphones? I don't know if they do or not. So, who would like to kick off with our first question? Anybody? No one. You've stunned them into silence. So, yeah. So I think one of the things that I've taken from all of you actually is this idea of some kind of longitudinal element to being able to, and cumulative knowledge. There just seems to be something, so from 3 quite different approaches, different kind of settings, there seems to be this thing about moving things forward, about bringing knowledge and building on, and that systems are somehow preventing that, or being a bit of an issue, and this seems to be a really big issue. So we talk quite a lot about context, but that seems to be quite a big thing. Anybody? Yes, brilliant. Thank you for kicking us off. Do we? Yeah, there you go.
Thank you very much to all of the speakers. Really interesting on this Kristian, if I can start with you, please.
Sure.
2 things I'd like to ask. The first one is, when you did your PhD, you said you were looking at mindfulness, trying to get more than 10%.
Yeah.
Sustainability. Did you?
Well, so 320 schools, and looking at historically, when implementation happens, usually about roughly 10%. I mean, it's not an exact figure, but so we sort of thought, well, 30 schools will probably implement it well, because they'll have the leadership will be on board, they'll have the right people in place, and they'll keep it a priority. And so what we did, we sort of, this is quite important actually, when you're analysing, especially with CIFA or some frameworks that are a bit like determinant frameworks, it's very useful to have multiple sites and to be able to rank them in how well they implement. So we had sort of 3 stakes in the ground, or 2 or 3, which was they would deliver it to year 7 or year 9, and they would keep it for sort of over 3 years. And so what we found was, to be honest, the funding got cut before we could finish the study. So it was big lottery funded. The first year, they gave 12 sites £1 million for the first year, and then after the first year, then 6 would get, I think it was 8 million or something like that to carry on. And unfortunately, Cumbria didn't get it. So we started all this, and we were engaging schools, and we see there's so many factors to this. But we had a local GP who everybody knew, so she could get her foot in the door. She could get meetings with the head teacher and explain what it was. And so it was all kicking off, but then it sort of it had to end really. But I did get a lot of data. I mean, I was able to go in depth to a number of, I think it was 5 schools, and use the CIFA they all perform slightly differently, and see what distinguished between them. And it was like leadership engagement, keeping it a priority, sort of formally appointed implementation leaders, so making sure it was somebody that could have decision-making power too. So the head teacher would get the head of year 7 to implement it. And the best schools, the schools that really got on board with it, were where they wanted a mindful school. It was a whole school approach. So I can't say really, because we didn't get to do the study. But, yeah.
Thank you. And then the next, sorry, I've been asked to use the mic. The next question is regarding your rapid relevant response evaluation.
Yeah.
If you look at sort of the process evaluation, process improvement models that exist out there, sort of your DMAIC or your PDSA, Plan, Do, Check, Act cycles.
Yes.
May I ask why you chose one? So I don't come from a qualitative background, and one of the things I struggle with is all the new frameworks, new models that seem to me to sometimes duplicate or replicate what may already be in existence.
Yeah.
And I'm just curious as to why a process like that, a process evaluation format like that, could not replicate or duplicate the 3R system.
So you mean the way it was implemented? Can that?
So if you look at that model of looking at research being, rapid, relevant, and responsive, and doing that evaluation cycle.
Yes.
Right. If one has used sort of the models from operations management or process improvement.
Yes.
Where you've got like that, plan, do, check, act cycle to kind of cycle back.
Yeah.
And I know those in the NHS might not be happy. So that it's all that Lean Six Sigma speak, or the DMAIC, the define, measure, act, innovate, check, that, those cycles that they use.
PDSA cycles. And
one would imagine that would generate rapid, relevant, responsive research.
Well, yes, absolutely. I mean, the reality is that teams like that, it's amazing how they're not sort of, there isn't somebody recording everything that's happening necessarily. They're just trying to achieve the goal. So in a crazy setting usually. So they would have a huddle every week, and they would do PDSA cycles and this test of change, but there wasn't necessarily anybody kind of keeping record. They were just, this is an issue, let's address it, let's move on, boom, boom, boom. ICU wards over COVID, for example, the same. Just getting there. There's not somebody actually keeping the notes, and so I think that's where we can come in as implementation researchers and really help that and facilitate it. But I agree with you. I think, look, we know that if you have an implementation strategy, you've diagnosed the context using the CFA, and you know what the barriers that people perceive the barriers to be. Once they start the implementation, you might have a strategy which is engage leadership or have a collaboration of leaders, but all those people have to come up with all the micro strategies to address that. Now, improvement practices, I think, are a wonderful way to do that. For them, it's a process, and when you combine implementation science and improvement practice together, it's very powerful. And that's what we're kind of trying to do. But I see your points. In some cases, if they're collecting the data and recording what's happened themselves, they possibly wouldn't need another evaluation team. It's quantitative data as well. I don't know about everyone else, but that seems very difficult to get in a lot of our projects at the moment, because it's another job. Somebody has to go into it. Somebody has to put numbers into a computer. They have to, and all the systems are different. And you know, there might not have been an engagement process. In one project, they didn't know what the intervention was when we started trying to collect data. So anyway, I'm going on. But,
Thank you. So I'm going to move to Carl now. Thank you for your question.
Thank you very much for those talks. They're all really interesting and good. And so my sort of question here is, it sort of starts with Charitini, but it works its way along the so one of the things that really struck me, listening to you all talking, is that isn't it true that everything is a pilot now? That nothing is intended to persist. Everything is intended to be overtaken by the next round of policy, because the policy cycle is so short, the technical development cycles are so short. And the question that I think is really interesting for people who are interested in implementation science, but I mean also for people who are interested in science and technology studies or political sociology or social economics, is how do we make sense of the constant process of change and disruption that's in front of us all the time? Everything's a pilot, nothing will persist. And it's that sort of project, sorry, this is becoming a lecture rather than I'm going to stop, but everything is a project now. All government policies are projects, and they cease to exist very soon in the policy cycle. So anyway, is everything a pilot now?
I think that's you, Charitini, to start.
Where do I start? So I think policy innovations are more likely to be exactly what you described, because they are more politically driven, and they certainly don't last more than not even a government cycle. And given the cycles of governments we have had recently, that it's a very short cycles. I do see a tendency, and I'll give an example, of the system recognizing that there has to be some change to move away from this idea of continuous pilots. And the first thing that comes to my mind is the role of the funders. So I think most funders now, when you come up with the idea even of a feasibility study or a pilot study or an RCT, they are requesting now, for instance, that there is a section that evaluates the sustainability of the innovation over time, and they want some sort of evaluation of the implementation of this in practice, which to me it seems that a recognition of the fact that it's not enough to just show that it works somewhere and it works for some time, but the idea that you need to start thinking beyond just the actual small-scale study that you're trying to plan. So there are some signs, in my view, that are moving us to think beyond just pilots. But the wider context that you're describing, I think it's hard to really change. But yeah. Sarah?
Thank you. It's such a good question. And I think it's interesting because I wouldn't say that everything's a pilot, because in the health justice partnerships field, there are partnerships that have been there for 30 years, and I worked very closely with partnerships that have been around, decades. So it's not necessarily a pilot. And also, I guess something that is maybe specific to health justice partnerships and maybe other preventative interventions is this has been done in the absence of policy. So there is no policy on health justice partnerships or integrated working. They have arisen because of the need, because of the experiences of patients who are experiencing hardship, and there is a need to support those people. So a lot of the partnerships that have arisen have come about through that sort of bottom-up rather than top-down approach, and that's given rise to all of the diversity that's out there in these partnerships. But I would agree that there's definitely, it was interesting listening to your presentation about pilotitis, because health justice partnerships, despite having been around for 30 years, are still being piloted, and there are still pilot studies out there. It just seems slightly crazy. But the reason for that a lot of the time is about trying to justify who should fund it. It's not that the evidence is there of the need, the evidence is there of the benefits, but there's a lot of squabbling over who should be responsible because it's not a medical intervention. So should the NHS fund it? Should the Ministry of Justice? Should councils? So I wouldn't say that they're all pilots, although many of them start that way to justify the funding that they get. I guess that would be my main reflections on it.
I agree with what everybody said. I mean, it's interesting because there's a lot of different stakeholders involved in these very complex contexts, and all with different agendas and different needs and desires. And it's very, when we, so this intervention I was talking about, I mean, it would have been, I didn't have time to really go into it in detail, but, it's become quite popular. And when if an ICB is approached about it, they will say, well, give us the business case from the last place that you implemented this, and we'll just copy it. And we say, no, you have to do this yourself. Like the team on the ground need to work out how this works for them. And we can do a brief test of change and actually you can build your own evidence base in your setting to see how this works. And so I like what you were saying about bottom up, because I think the system's probably, it's so complex now, I don't think anyone's really got a handle on it. And things are often funded which perhaps aren't, and actually they're not helping anybody really, but they keep being funded, and the research it's good for everyone apart from the people it's supposed to help. I'm not saying this happens all the time, but it can happen, right? So we have to be really careful. But I think I'm very keen on empowering localized staff to actually have the time to work out what's best for them. So instead of somebody saying, we're going to fund you this pilot, well, ask them what they actually need, to do what they're supposed to do in that setting. And so perhaps part of the answer is, empowering local teams to do what they need to do to actually make things work well. And just final point, we had 40,000 nurses leave the NHS in the last year because it's not actually been a great place to work. So another thing we've been trying to do is push and encourage everyone to make it a nicer place to work. Give people time, a bit like Tim was saying yesterday, give people time to think. And so maybe we'd get out of this funding cycle.
Yeah, Corey.
Thank you. So this is going to be a long one, I think. So the too long didn't read is hierarchies and power is where I want to kind of think. The question I think is to you all: who do you wish that you would have listened to? We had a session with Carl. He was like, qualitative research is not about talking, it's about listening. Who do you wish that you would have listened to in your projects that you didn't get a chance to listen to, who would have gave you some insight? And thinking about how MPT involves conversations with folks who are doing the work. And you mentioned a little bit about the bottom-up approach. I engage quite a bit in population health work and then equity and all those places. And so thinking about how those voices begin to help us shift ideas and the work and how implementation should happen shows up for me. And then this is a little related to the rapid approach, right? The slow science is that it's, well, let me just say this, that the rapid science can easily become just about technocratic fixes. So how do we engage other voices and who may actually need to be capacitated, right, to be able to participate in developing methods of translating the evidence? All of that.
That's great. Sarah, do you want to kick off?
Okay,
Is
sure.
that all right?
So so for me, I think in my study, the people that I wish I could have engaged with and did more to engage with would be the patients. I hadn't designed my study to involve patients because it was all about the systems, the processes, management, all of that. It would have required quite a lengthy ethics approval as well to do that. But I think one of the aspects that is underexplored in the implementation literature is the patient experience of different approaches to this and their needs, which could help us think about the important aspects of service design. And I completely agree with you about the importance of the patient voice here, or the community voices, because it's something that I guess I'm quite conscious of. We describe inequality all the time. We communicate the data, we show the charts about these differences, and yet we don't do very much. And I think one of the levers for change potentially is communicating those experiences much better and getting those stories out there so that the people making decisions about what to fund and what not to fund are hearing those experiences. So thank you.
Charitini?
So in our case, the setting was such that we spoke to the HSNs, the Academic Health Science Networks, because they are intermediaries in the process of, in this structure of the NHS. But what is missing from this side of the story is the story of the innovators, those who are trying to get into the system and reach patients and spread their innovation more widely, which we have started doing with another project to see their perspective into this, how they experience it in practice, and what are the challenges they find, and why, from their perspective, they have to repeat the pilots here and there, and also how do they think things should be done differently.
Kristian?
Yeah, so imagine there's a big problem in society that needs addressing, and then somebody comes along with a solution, and so the people at high up need a solution because it's politically what they need. So they take on this solution, and then there's a scientific process to see if it actually works. And so there's lots of different voices involved, from the research team doing the evaluation, could be the practitioners and the public. Everyone ideally would be involved in that. But I think it's not sort of negative, or it's not sort of overly negative to think sometimes this doesn't work so well. So it's sort of, there's something going on to address a problem. I've touched on it before, but it's not really addressing the problem. But it's sort of working for everybody. And I think there should be things in place to stop that. And I do think what you're sort of talking about, this power and hierarchy, is very important that the people it's supposed to be helping have a voice. And if it's not helping and that's inconvenient, we really need to respond to that, even if it has a negative impact on the way it looks politically and the way it looks in terms of funding. So now you said the question, who do I wish I'd spoken to in that study? Well, it's very interesting because the implementation was absolutely brilliant. When we were evaluating the implementation, I actually think that's a great way to implement. Engage, test of change, and this guy, those domains, he knew them all. But there was one group that weren't turning up to these meetings. It was only at the end that we spoke to them. So throughout, we thought this thing was the best thing since sliced bread. It was saving ambulance hours. But then when we spoke to this group at the end, I'm being deliberately vague, they actually said it hadn't helped at all. And then they presented raw data to prove this. And this didn't go down so well, with the group. So this is just a reality. You've really got it as an implementation researcher. And Alison Metz talks about implementation support practitioners. And she has this fabulous model of, all the personal skills you need. Being able to relate is a really important one. Being able to relate to all the different people. You've got to make sure you're doing that. We made a big mistake there by not talking to that final group until the end. So try to get all these stakeholders to empathize with each other, to trust each other, and be on the same page. think that, oh yes, and you asked about, yes, all voices, yes, that was it, all voices about the rapid approach. Well, I think lightning reports are fantastic for that. You know, I can just ring, I could ring some, obviously you'd have to get the ethical approval and everything, but you could speak to a patient and ask them what's going well, what's not going well, any key insights, you know, and combine that with what the doctors are saying, with what the other rest of the team's saying, and then put it all together and then give it to everyone. So you're kind of making sure that all those people are getting a voice and it's being seen. Yeah.
Okay, great. We've got time. Yeah, brilliant. Thank you, Charlene.
I just want to repeat how wonderful each of those presentations was. It was just phenomenal. Really, really great insights into your projects. I spend a lot of my time thinking about rapid research, so this question is probably for Kristian. And it was a great segue there with the lightning reports, because one of the things that I've noticed in reviewing a number of rapid research projects is they often omit discussions about their dissemination approaches. And it just seems like such a fundamental part of rapid research to sort of feed back in. So I was curious if you could say a few words about how you use the different approaches that you used to sort of applying these lightning reports, and potentially, if you can, what sort of actions they led to. What did people do after you shared your findings, and how did that impact your project? Thank you.
Thanks. Yeah, so the way, again, it's never, it should, well, I don't think it should be a canned approach. So it's, you've engaged everyone, everyone's clear on the goal, and you want them to get on with the implementation, but in the most unburdensome way possible, really. You want to try to get data from them so we can evaluate the implementation. And we may or may not decide to facilitate, depending on, again, it depends on the intervention, the context, and everybody's needs. And so in the case of this study, we did sort of some baseline interviews just to get an idea of the context. What did they perceive was going to be a problem? Did they all have a way of, did they all sort of agree on where this was going? They understood how it's supposed to work, that sort of thing. A bit of readiness, you know, were they motivated? Did they have capacity? And then it was actually asking, we start with the sort of lead, whoever sort of seems to know the most about the implementation effort, and ask them, what's the best way for us to keep contacting you? You know, is it okay? Do you want us to come in person? Can we ring you? It'll only be 10 minutes. And it's that relating piece. It's like, I always say, look, you're the ones doing the implementation. So you're the ones who are going to learn how to do this, right? So in a way, you're the experts. We need to learn. We really want to learn from you. And then that often gets people more engaged. They go, oh, okay, yeah. And so with this project, we every 2 weeks, we went to visit them in person the first time. And then because they were quite far away, it was a couple of hours on the train, we'd open a Zoom call for 2 hours, and then all members of the team could drop in any time they wanted. Because they're busy doing their job, that it's very hard, you know, to get that time. So they'd drop in, and then we would start to ask questions. You know, we have the CFID sort of guide us, right, on if we know if...
Yeah,
Please,
okay.
yeah. So.
Thank you, Charlene. Right, we've got 2 questions left, so I'm just going to move on to those. So, Elvin, you're next, and then it's Tim, and then we'll close the session. So, Elvin? Where are you? I can't see you.
Back here.
Oh, there you are.
Good morning. Phenomenal presentations. Such a pleasure to be here and listen to the discussion. I'll be as brief as I'll try to be brief. So one of the things that I heard kind of running through the presentations was this idea of sense making, and in particular sense making that's associated with practice, right? That we can't necessarily get out of you know, a piece of evidence that comes in a guidance document. And I have 2 questions related to that. One, the first one goes to Kristian, which is, did you find in your sort of rapid touches, did you see a process of sense making unfold, and how might that differ from a qualitative process that touches them in a sort of less frequent manner, right? Does that reveal something about how sense making occurs that's specific to the method that you deployed? And I wonder if you could speculate on that. The other question is sort of related to the piloting and pilotitis. You know, I wonder, you know, maybe there's, you know, different users need different types of information about a particular innovation, and sometimes perhaps one person's pilot is, you know, another person's sense making, and there are probably, I guess I wonder in the data that you have, whether or not that sort of idea of sense-making, adaptation, owning, understanding how it feels, the muscle memory that goes into a practice sort of came up. But those are my two questions. And
thank you.
Sorry for being long-winded.
I was just going to say, Tim, do you want to just give your question as well, and then we'll just get the panel to finish off? No. Okay.
We'll go in a different direction. Just focus on one.
Okay.
I'll keep
Thank
it really quick. Everybody's going to need a different amount of help. So there'll be this project. To be honest, didn't really need our help. They had an improvement specialist. They did tests of change. He was on it, right? Didn't really need us, but we got some amazing stuff, right? So we got really good data on how to implement. Right, we've got a process now. We've laid out a process map of the way he did it, and we're going to use that in future sites. But there might be other teams that don't have an improvement specialist, don't really know what the intervention is supposed to do, don't have a way of implementing it, don't really understand the context. That's where we can still evaluate and get what we need, but we can offer an awful lot. We can help them understand the context, we can give them a way to implement, we can help them with lightning reports and other ways of facilitation. So the sense making will really just differ from every project.
Okay, thanks, Kristian. Charitini?
Yeah, very briefly, sense-making is vital in the evidence mobilization because it does, indeed, evidence is in the importance of evidence lies in the eyes of the beholder, right? So every different actors understand evidence in a different way, and that's exactly what the data shows. But that doesn't mean that evidence cannot be generated when you bring the different stakeholders together to understand what is it exactly. So a practical example from our data was an innovation that actually managed to spread, because in the beginning of the pilots, when we started understanding the effectiveness of it, which is what the clinicians want. They also involved patients to understand acceptability of the innovation. They involved, they had health economics input so that they convinced managers. So definitely for us, and it is well documented in the evidence mobilization, indeed, literature that this is important, and we do see it a lot in the data.
Okay. Tim, is this going to fit in this gap, or should we go on?
No, okay. I'm just going to briefly have a rant.
I knew.
In 30 seconds.
Go on then.
There's something interesting. In a time of ongoing turbulence, which is what we're in, turbulence is the default state. If you look at COVID was rendered as an emergency. There is a constant emergency going on. And actually, if you look at the emergency literature about how you do disasters and other kind of things, we are now in full stop turbulence. Yeah. My concern is there is a narrative that there is constant duty to innovate. And should we be doing that at all times? Should we at times be consolidating, not innovating? Should we be at times being more generous about what we've got and seeing what we've got and not doing the next and the new? Now, that doesn't fit in with the funding structure. That doesn't fit in with capitalism, to be brutally honest, in my leftist kind of angle. So there's something about, we need to think seriously about why we are doing what we're doing and when we're doing it. And part of what we can do in and through qualitative research, which we lose, is bringing out some of these different textures, bringing out some of these political impetus, which we don't get in IS work, because it's so RCT, EBM kind of genre. So there's a kind of level, my question is, should we always be doing this? And we may be talking ourselves out of a job at times.
I can answer 2 seconds or?
You can, yeah, go on then.
You're right. Quality improvement implementation can make things worse. It can add to the burnout, meaning more staff leave. I think we need to think about de-implementation, and we need to be really careful when we do push to implement things and make sure it's what people actually need.
Thank you.
Therefore, we're just doing work on the implementation of implementation.
Yeah. So I'm going to close the session. I'm going to ask you, hold on. I haven't finished. I'm going to suggest that you take those lovely big ideas to the coffee break with you. And that actually, I think that certainly the workshop that I'm about to do, that's so relevant to what we're about to talk about. So I think that'd be good. So talk to them, have a cup of coffee. I just want to finish by thanking our speakers for their presentations and